Hi, many of you have been wanting a video on ventilation graphics, mainly related to how to interpret the loops and the waves that we see on the ventilator screens. I'll try to cover some of these. So we do have more sophisticated ventilators in the past 15 years or so, and no doubt synchronized modes are routine. We hardly ever use non-synchronized modes, and volume guarantee is the more preferred mode for obvious reasons. So we have waves and loops. Waves are basically scalar, where there is a component against the time. So we have the pressure, flow or volume, and one of these components is compared in relation to time. The loops compare pressure volume or the flow volume, and here time is not a factor. So we can look at different aspects of the ventilation, the effectiveness, whether there is any leak, whether there is any spontaneous triggering, and over distension, obstruction, and so on. We also have the measured parameters, the compliance, the resistance, tidal volume, minute ventilation, and if you are on high frequency, you have high frequency minute ventilation, high frequency tidal volume as well. The DCO2 is another component. So we have different components which can guide us in how to ventilate the baby, and if you're using volume guarantee, we need to decide on the correct tidal volume for the baby. And also remember that the settings may be different if you're not using volume guarantee before surfactant and after surfactant. So when the lung compliance improves, things change dramatically. So just a quick overview on the volumes that we talk of, and we have only two important volumes that we need to look at in this chart, because for newborns we have the tidal volume, which is the actual movement of gas flow into and out of the lung with each normal breath, and in the case of a ventilated baby, ventilator given breath. And we have the functional residual capacity, which is the air remaining in the lung at the end of a normal or a tidal expiration. So it's not a forced expiration. A newborn is not expected to do anything else. And so the functional residual capacity is what is remaining in the lung at the end of expiration. And it's very important to maintain a good functional residual capacity, because if the FRC goes close to residual volume, the closing volume of the lung may come up and atelectasis becomes more likely. So here we are aiming to use optimal or recruit optimal FRC, so that we are not in the over distended zone or we are not in the atelectatic zone. So the compliance of the lung is best reflected in this depending on the incline of this curve. We'll discuss that later. So this is volume and pressure. So the unit change in volume for a unit change in pressure is what compliance is. And then there is a playlist on ventilation, and I've covered many of these basic terminologies in that. I'll link in the video info for this playlist as well. So now we'll go through each of the loops and the waves. First for the waves, and we have the pressure and time scalar waveform. We have two forms of ventilation, volume ventilation and pressure ventilation, and most of us in newborn use the pressure limited ventilation. Volume ventilation is used in certain units, but due to leak, due to non-cuff DT tube and other factors, it's not used. Of course, we use pressure limited ventilation with volume guarantee, which combines the features of both of them. So in pressure modes, the shape of this pressure time scalar will be rectangular, and it can be a little bit of a sine wave where the slope is slower, where the flow is set to rise slowly, and it can be a square wave where the flow is kept on the faster side. So a ventilator like Drager, for example, you can choose a rapid rise versus a slow rise. And in a volume targeted ventilation, you have the pressure increasing gradually till the required volume is met. So it's not an abrupt increase. The volume time scalar is usually having a mountain peak appearance at the top, and it may also have a plateau at the peak. So you have a slightly different appearance compared to whether it is volume targeted, where the peak happens more acutely, and whether it is pressure targeted ventilation. If it is volume guarantee, you'll reach the same volume every time. And so this is the beginning of inspiration. The tidal volume is reached here, and when exhalation begins and reaches back to baseline. And the baseline is usually the FRC of the lung. So in the volume time scalar, if the volume cuts off abruptly, it's called cliffing or shouldering, and that indicates usually either air trapping or air leak. So the air leak can be air around the ET tube leak, or it can be a pneumothorax as well. So chest drain leak from a pneumothorax. So we have these parameters which guide us in this volume time scalar. The flow time scalar is quite useful in different ways in judging whether your inspiratory and expiratory times are adequate, in judging whether there is any airway obstruction, and so on. So in volume modes, the shape of the waveform will be square or rectangular, while in pressure modes, usually it has a decelerating ramp. So as we use mainly pressure ventilation in babies, this is the pattern you'd be seeing. And this is more in the PICU and adults where volume ventilation is used. So we have the beginning of inspiration and then the beginning of expiration. The time is on the x-axis and the flow is on the y-axis. So in this example, we have inadequate expiratory time. So the expiratory time may cut off here, then you may have air trapping. So suppose your exhalation is not complete, you have auto triggering happening at this stage itself, then you have over distension of the lung, and we call it auto peep. So auto peep is where the expiration is not completed for whatever reason, and the exhalation continues. It can also be, the same pattern can also be seen in leak in the circuit as well, or auto peep. Both can have a similar pattern. Here we have the bronchodilator response. So if we have a very prolonged expiration and the flow is coming back very slowly, you can give a bronchodilator and you can see it comes back quicker. And in terms of secretions in the airway, you will have irregularity here, and you would have a more prolonged expiratory phase as well. So we have a different pattern in volume mode, as we discussed, a square waveform versus in pressure mode. So we have in volume modes, we have the pressure scalar as having a triangular appearance, while the pressure scalar here in the pressure mode is square. The flow mode is square for the volume mode, and it is ramped or triangular in the pressure mode. You can see that if it's a flow trigger, the flow inspiratory flow does not come back to baseline, because you have a flow trigger set at like 15 to 30% of the expiratory, the flow. When the flow drops to that, it picks up as expiration and stops the ventilation. So you have this kind of ramp if it's a flow trigger. If it's a time trigger, you would not have that cutoff. It will come to the end. And the volume ventilation, you have a slight plateau at the top in volume, and pressure limited, you have more triangular appearance. So in this example, we have the flow which is kind of dropping abruptly in inspiration. So the smooth drop is not seen. So you can see here that if the inspiratory time had been longer, it would have come down slower and then the expiration would have started. But here it is dropping off rapidly, which means the I time is short, and increasing the I time is a response to this. And in this case, you can see that the expiration is getting short. If the rate is too high, you may have fluid in the circuit. Again, we discussed auto triggering, where the expiration cuts off quickly and there is the air not coming back to the baseline, the flow not coming back to the baseline. So in these cases, you increase the respiratory response, and the improvement happens in the flow pattern. Next, we'll come to the loops, which are basically the pressure on the x-axis and volume on the y-axis for the pressure volume loops. And inspiration is typically in this direction, and expiration is coming backwards. And usually the starting point is a peep, because the pressure doesn't drop below the peep. And the inflection point is where the volume starts increasing quickly, and you can decide on appropriate setting and need for surfactant based on how much pressure is needed. As we discussed earlier, compliance is nothing but unit change in volume for a unit change in pressure. The stiffer the lung, the higher the pressure you need to reach the inflection point, and a higher PEEP might help these babies as well. So the work of breathing is also reflected, and if there is increased resistance, you would see a widening in this part where the work of breathing is more. If your pressure continues to increase with no actual increase, no actual change in volume, that means you have reached the opposite end. So if you have less ventilation, you have atelectasis in the lower part, and if you have beaking, that means you are giving unduly high pressure with no benefit because you are already over distending. So you need to drop back, come back down in the pressure to an area of the curve where it starts dropping again. So this is an important sign that you are over distending or giving excessive pressure. Remember that we have something called iatrogenic persistent pulmonary hypertension. If you're over distending the lung in the first 3-4 days, you're compressing the pulmonary veins, your pulmonary pressure increases, and you're causing pulmonary hypertension. So the baby may behave as if they have PPHN, while actually you are creating the problem by giving more pressure. This happens if you don't wean the pressure appropriately post surfactant. So it's very important to monitor these aspects. And volume guarantee, of course, is a very big bonus in these situations where even if you are not changing it, if you keep the tidal volume appropriately, it will likely improve. So we have different patterns. So you have RDS or lung hypoplasia where it's very steep, and then you have the normal lung and in over distension as well. So you can have changes in compliance reflected on the pressure volume loop, and this can guide you on the need for surfactant and the response to surfactant treatment as well. So here you can see the hysteresis phenomenon, and we always use the phenomenon of hysteresis when it comes to weaning or keeping the appropriate setting on high frequency. You're all familiar with the volume recruitment. So the lung recruitment happens, you keep increasing the pressure on high frequency, the MAP, till the FiO2 reaches a certain level. It's reducing to say 30 or 35%. And once you reach that, you can go back down on the pressure, the mean airway pressure, maybe 3 or 4 centimeter in some cases, or at least 2, till the FiO2 starts rising again, and that might indicate the point where you are keeping the pressure reduced with maintaining the same volume with the principle of hysteresis. So you can see here that the volume stays the same from this point of pressure till this point of pressure, and this is the principle of weaning the pressure once you achieve the lung volume in high frequency. You also have resistance manifest as widening of this, so the same pressure will cause the rise, but the time taken is more. So you would see widening, and expiratory resistance is more common with airway obstruction with secretions, and inspiratory obstruction, as we will see, is more if there is kinking of the tube or other issues. So if there is a sudden increase in resistance, you look at the tubing, the secretions in the circuit and so on, secretions in the tube and this. So if the pressure volume loop doesn't come back to baseline at the end of expiration, it indicates a leak. So we have a few waveforms or loops and waves where we can look at leak options, and the expiration not coming to baseline is one marker on the pressure volume loop as well. The flow volume loop is quite useful, and there are many situations which affect it. Here we have the flow in a positive direction and a negative direction, and remember that the alignment of this may vary. The ventilator may have inspiration on the lower side, the positive flow on the lower side, and negative flow on the higher side. The inspiration on the lower side because convention on the ventilator is that way. So don't be confused. Try to see with the ventilator breath where it is going with the inspiration, and then you can figure out whether it is up or down. In a couple of diagrams here, the inspiration is upwards and expiration is downwards. So we have the inspiration, we have the expiration. Expiration being a passive process, once it starts coming down, it continues dropping and it reaches the baseline here. So we have the start of inspiration, the inspiration completes, the expiration starts, the peak expiratory flow happens, and then the gradual drop till it comes back to baseline. So we have a few examples of different flow volume loops being abnormal. So this is a normal loop. This is showing a kind of ski slope in expiratory flow limitation. So we have flow limitation. This is inspiration in this case. And we have extrathoracic airway obstruction with both inspiratory and expiratory being affected. And in intrathoracic airflow limitation, this is the inspiration, so there is limitation of the inspiration and the expiration is going in the normal direction. So you can see the difference between the inspiration and the expiration. If there is an unstable airway, like in a laryngomalacia, it collapses in during inspiration, then opens up again, and then expiration is irregular as well. And here it's inspiration downwards and expiration upwards, so the secretions in the circuit is causing erratic flow. This secretions can be in the circuit or it can be in the airway as well. So you have different patterns here, and again you have a leak which results in expiratory flow not coming back to baseline. So we have the pressure volume, the flow scalar, and we have the flow volume loops all showing changes with a leak. So the leak around the endotracheal tube, we have the normal waveform, and here it doesn't, the cliffing happens, and we have the pressure volume loop, it doesn't come back to baseline, the flow volume loop, it doesn't come back to baseline. So you can have the flow volume loop which is upside down as we discussed, so inspiration and expiration can be reversed, and in this case with the airway obstruction, the expiratory curve is scooping. So this is because of the obstruction and it's prolonged. We discussed air trapping earlier, auto PEEP. It happens with insufficient expiratory time. There is early collapse of the unstable alveoli or airways during exhalation. And you can see this on the flow pattern when the expiratory flow doesn't return to baseline. Remember that the pressure wave, when we are using pressure limited ventilation, doesn't give much information because it's going to stay the same. In volume ventilation, the pressure wave gives more information, but in pressure limited ventilation in the NICU, we are not going to see much. So you can use the pressure wave mainly to see, for example, in the Draeger, the VN500, the pressure that we reach can be seen on the pressure wave compared to what you set in the volume guarantee modes. But otherwise it doesn't have much function. The flow and the volume waves, it doesn't return to baseline, and the loops also, as we discussed. And leaks can happen through an expiratory leak at the ET tube leak. You are not using a cuff tube in babies, of course, according to the size of the tube. You can have a chest tube leak if you have an pneumothorax drained, or a bronchopleural fistula can be leaking. And inspiratory leak can happen with loose connections when the ventilator starts malfunctioning or if there is a faulty flow sensor. So we can identify it by the volume wave where the expiratory flow doesn't. So there's not much difference between auto PEEP related changes and the leak related changes, except the clinical setting would be guiding you, and expiratory side doesn't return to baseline in these as well. So we have to check the leaks. You can see the measured leak in the ventilator measurements. So if you have more than 40% leak, your volume guarantee modes may not work. Of course, some ventilators have compensation, leak compensation, and you can use that. But remember that we are trusting the machine to do it properly. So if you know your ventilation basics, I mean, for many of us who trained in the era before we used volume guarantee, we are comfortable using synchronized modes like SIMV or SIPPV or assist control. So we are happy to switch, but the newer trainees, because they are used to volume guarantee, they are hesitating to switch. Remember that if you use it sensibly, if the pressure limits you use are sensible, you are weaning quickly, that's the key. You are watching the baby, you are watching the settings, you are weaning quickly, then both modes shouldn't be much different. Asynchrony can be picked up as well. During inspiration, there is a kind of scalloping as well, because the baby starts breathing, so the negative pressure generated by the baby takes it down, and then the ventilator may compensate. So you can see that in the pressure volume loop as well, where the baby's negative pressure drops the pressure delivery. So remember that the baby's direction of flow and pressure are both opposite. That's how the ventilator senses the baby's breaths. The flow changes and the pressure changes according to what trigger it is using. And compliance changes, of course, when we are treating RDS, we see a significant compliance change with surfactant, and these are the differential diagnoses for where the compliance might reduce. Of course, abdominal distension, lung collapse, heart disease, consolidation, pneumothorax may all contribute in addition to RDS. And in the pressure volume loop, it will be more horizontal. As we said, the pressure wave won't be much of a guide in newborns. Unless you're using volume guarantee, you can see the delivered pressure to compare. Increased compliance, of course, post-surfactant therapy, we have to be careful to wean appropriately. In terms of asynchrony, we discussed already, so it can happen due to air hunger if you are not giving adequate flow or pressure to the baby. If the baby is breathing against the ventilation, it may mean that you need to give a little more support to the baby. In neurological injury, of course, the baby may not trigger appropriately, and if your sensitivity is not set appropriately, if it's a very small baby, you need to keep a lower sensitivity. If it's a bigger baby, keep it higher flow trigger according to the baby's size. So we already saw on the flow volume and pressure volume loop how the asynchrony manifests, and you can try to adjust the respiratory rate, you can try to adjust the trigger settings, and we can change the mode as well. If it is a neurological condition like irritability or seizures, you may paralyze or sedate the baby. And the rise time we discussed in the beginning, if it's a square wave, the pressure goes quickly, and if it is a sine wave, the pressure goes slowly. You can adjust it in some ventilators, but in general, it's not going to make a huge difference, because most of the recent ventilators, they adjust the flow themselves. And cycling off of the inspiratory flow, suppose you are using a PSV mode of ventilation or SIMV with PSV, during the PSV breaths, the expiration starts. So remember that the I time is controlled by the baby in the PSV modes. So the ventilator cuts off the inspiration at a certain cutoff, and that is what the inspiratory cycle off point is. So you have the 100% of the flow when it drops to 75, 50, 30, 15 and so on. So anywhere between 20 to 30% is where we normally aim to keep the drop. If you keep higher than that, the baby may not get adequate inspiration and atelectasis may happen. If you use too long, then the baby may start asynchrony by breathing against the ventilator. So if it is too short, you get inadequate inspiratory time. If it's too long, here you can see the exhalation spike because it's a volume control mode, and this is because you are seeing the baby breathing against a sign of asynchrony. Finally, we'll discuss a little bit about volume guarantee, and we all know what volume guarantee is. So we are trying to cut off the pressure when the expected tidal volume or the set tidal volume is reached. The key things here is to judge what tidal volume the baby needs. Each baby is different, each lung condition is different, and the size of the baby, the age of the baby, the lung condition, all these make a difference. So normally we keep 4 to 6 ml per kilogram. The smaller babies we keep close to 5 to 6, and the bigger babies 4 to 5. In the older babies we may need a higher setting of the tidal volume. And in a baby who is being ventilated for neurologic conditions, who has a normal lung, we need to keep a higher, because the lung compliance is good, you need to keep a higher tidal volume. So the ventilator senses the tidal volume of each breath. It measures the previous breath and then gives the next pip, and then it sees the measured volume and adjusts accordingly. So here it's obviously self-weaning. So as the lung compliance is improving, the pressure starts reducing for the same volume that is delivered. So that's the main advantage. The main requirements are that you need less than 40% peak. You need to still assess the baby's breathing effort, the carbon dioxide levels on the blood gas, the oxygen requirement and so on. Sometimes we see inappropriately low PIP being delivered, and that means you may need to increase the tidal volume to a level that the baby needs. The baby's work of breathing tends to be high if the flow difference, the pressure difference between the PIP and the PEEP is too low. So you are essentially treating RDS, the baby is breathing hard, then the purpose of work of breathing is increased and it's not going to help. So you may have to change him briefly for a period of time on a controlled breathing like SIMV with pressure support. And once the breathing gets better, post-surfactant, you can change them back. This happens only in some babies. So if you notice increased work of breathing after surfactant on a volume guarantee mode, either you need to increase the volume or you need to change back to a synchronized mode and change back. So what you do depends on your unit practice, and I often say that you shouldn't be dogmatic about a particular mode, majority of the time, 90% of the time, volume guarantee works, but in the 10% that you feel it doesn't work, don't hesitate to change back. As I said earlier, if you are using the right pressure, if you are not over ventilating the baby, you have to judge what pressure is needed, and that's where our previous experience with using these modes helps us as well. So the newer generation as well, try to look at the babies, what pressure they're needing on volume guarantee, so you get an idea of the size of the baby, the pressure that you say is acceptable for that baby, size and trunk disease. And then if it's going too high as well, you need to check whether the baby really needs to reach that PIP, because it's ultimately the pressure that reaches the lung that damages. So even if it's a volume guarantee mode, if the baby keeps getting 25 PIP, well, actually you could manage on 21, 22 PIP on SAMV, I would prefer the SAMV mode. So both extremes are not good. So you have to balance it, and you can always keep on one mode for a few hours and change back. It's no hard and fast rule that you should stay with the single mode. Avoid sedation as far as possible. So fighting the ventilator is mostly because you don't have the right settings, and if you keep the right settings, you don't need to sedate the baby. We hardly ever sedate, and only in severe PPHN or diaphragmatic hernia and so on that we sedate for a period of time. Avoid midazolam as best as you can. You can use fentanyl or morphine. So just the last slide on whether volume guarantee is suited for all the situations. So we have many benefits shown in studies that volume guarantee reduces death, BPD, pneumothorax, ventilator days, hypocarbia, PVL. So there is no doubt. But the main reason volume guarantee helps is because in many units, they follow a systematic approach. They don't look at the baby, they don't look at the measurements, they don't look at the loops and curves, and they don't make the changes in a timely fashion. So if you are changing appropriately, volume guarantee shouldn't be much different than the other modes. The things against volume guarantee is that you need an appropriate tidal volume target. Unless you get this right, it won't help. And you may have, if your settings are not appropriate, straining, spontaneous breathing, diaphragmatic interruption, and you have short eye time, which can be a problem as well. Unless you keep the Imax as adequate, it should be higher than what you would normally keep. And triggering can happen if the baby is breathing fast as well. And leak will make it difficult to rely on volume guarantee. So we have to rely on the machine to a significant extent, and if the machine fails for any reason, then we will be in trouble as well. So remember that there is a video where Dr. Bankalari discusses this aspect, and most of the aspects that I discussed are similar to what he discusses in that as well. So in general terms, we have to be clear about what we want to achieve, and what mode you use to achieve that is purely up to you. Ventilation is a blend of art and science, and we all use more non-invasive ventilation. Timely surfactant is important. You can refer my video on pragmatic approach to RDS and the European consensus guidelines for RDS as well. So aim to extubate at the earliest possible. Use less invasive modes for surfactant delivery. Situational awareness is key. You have to look at what is causing a particular problem, troubleshoot it, and your aim is to support the baby just enough to progress over the situation you're facing. You don't want to overdo things. As I mentioned with the iatrogenic PPHN, overdoing things is going to be negative for the baby as well. Use available resources and options sensibly. Seek help if you are in trouble. Don't hesitate to call your consultant on call if your system allows that. And we discussed this earlier. Don't hesitate to change the strategy if one technique is not working. Don't be dogmatic about it. Educate and alert the team members to review these, so the nurses may be able to tell you if the baby has asynchrony, if the baby has a leak happening. And we have lung ultrasound now where you can quickly take it to the bedside to see if you don't expect a leak, if the measured leak is less, it could be an air leak for the baby if it suddenly comes up. So you can diagnose a pneumothorax quickly that way as well. And remember that though volume guarantee is a good mode, don't be stuck on it if it is not working for any reason. You try your options, see whether the pressure that is delivered is commensurate to what the baby needs on both extremes. A very low delta P is not good. The baby's workup breathing may be more. It essentially becomes, suppose the baby is having a tidal volume of 6 and you're achieving that with a PEEP of 10 or 11, and your PEEP is 5 or 6, your delta P is only 5. So the baby is getting essentially a delta P of 5, and that is basically like ET CPAP, which is not ideal, and we want to avoid the increased workup breathing in the tiny babies, and that's why I mentioned a short period on SAMV in this group may be okay. If the pressure is reaching consistently 25 to achieve a tidal volume of 6 and the baby needs that, but actually baby may manage oxygen requirement is not that high, and you can try a period of SAMV on a setting of 22 pip, for example, which is more reasonable, more gentle on the lung if the baby is around a kilo or so, than reaching a pip of 25 consistently just because you want volume guarantee. Adjusting the tidal volume is of course an option, but you can change the modes as well if you are more comfortable with that. So this is just to give you an idea that you don't need to be dogmatic in the approach. Of course, in my experience, 90% of the time volume guarantee works well, but you have to watch for the 10% where it doesn't, and don't hesitate to switch. So I hope this discussion has been useful to you and achieves your objective. I kept it simple intentionally because in real terms we are not going to use the flows and the waveforms to a great extent unless you are in trouble. But it's a good practice to review that during every rounds, teach the nursing staff as well how to interpret and inform you if there are changes. Thank you.